Good afternoon, everyone. I'm Ilsa Connect, and I'm the Deputy Director of Public Policy for the National Center for Victims of Crime. I want to welcome everyone to today's web seminar, Forensic Nurse Examiners Beyond Sexual Assault Examinations. I want to go over a couple housekeeping issues for those of you who are not familiar with the WebEx system. This slide is just reminding everybody that the audio is coming over your speakers today, and if you're not hearing audio, make sure you first try to turn on or adjust your computer speakers. If you have problems with the audio or technical issues, please go ahead and call WebEx directly at 866-229-3239. I want to let everybody know that all the attendees that dialed into the call today are in what we call listen-only mode. So you will not be able to verbally ask questions. You will be able to ask questions using the question mark icon, question mark toolbar. For some of you, you may see it on the right side of your screen. You might have to actually maximize that panel. It says Q&A. If you are in a full screen view, it may appear as a floating toolbar. You can see the little picture here on the screen. You click on the little question mark icon, and that opens the box to ask questions. Type your question in the little box that's available and hit the send button. Only the panelists today on the webinar will see your question. It is not available to everybody on the call. We'll be doing our best to answer questions today at the end of the presentation, but if we don't get to your question today, we will follow up with you by email with answers. Also note that the chat function is not enabled for this webinar, so if you need to reach us, use the question and answer tool. And I get this question a lot. You are not the only person on the webinar. I know that you can't see the other participants, but there are now about 140 people actually on the webinar, and we have about 250 people registered. Okay, when you logged on, you may have noticed a poll at the right side of your screen. We hope everyone got a chance to complete this poll, but if you haven't done that, please do so soon. You also need to make sure you hit submit to send us your answers. These polls help us measure the effectiveness of our training, so we do really appreciate you taking the time to fill that out. I want to just tell you a little bit about the National Center for Victims of Crime before I turn the webinar over to our presenter. The National Center's mission is to forge a national commitment to help victims of crime rebuild their lives. We do this through direct support to all victims of crime, all types of crime, on our National Crime Victim Helpline, 1-800-FY-CALL, and through our website and through email. And you can see the email and the website here on the screen. Victims can call our helpline or email us to get information about compensation, safety planning, and their legal rights, among other types of support. We provide training and technical assistance to those who work with victims, and we work with Congress to secure funding for victim services and rights and protections for victims. Since 2002, the National Center has been focusing on increasing understanding of forensic DNA and DNA technology among those who interact with crime victims. Our work has focused mostly on maximizing the potential of DNA technology because we know that we will solve more cases and we can prevent more crime and bring answers to more victims by doing so, by maximizing the technology that we have. We'd like to thank our funders, the Office for Victims of Crime at the Department of Justice, who support our work through a Recovery Act grant. Our goal is to ensure that professionals who work with crime victims have the most up-to-date information about DNA so that they can provide accurate guidance to victims whose cases involve DNA evidence. This webinar is the fourth webinar in a series of 8 that are geared towards an audience of victim-serving professionals. Our next webinar will be on October 28th, and that will be on working with victims in cold cases. So stay tuned for announcements about those webinars. I want to mention that we have created a listserv for those who are interested in DNA-related issues, and we have developed materials about forensic DNA for victims and victim-serving professionals. Those are available on our website. You will also find news articles about DNA and interviews with professionals in the field and survivors who have important stories to tell us about the power of DNA, and that is all on our website, and including an interview coming up soon with Jennifer, our presenter today, and that will be on our website in a few weeks. So here is the web address for our online DNA Research Center where you can find all of this information. And this is my contact information. You know, I just realized my cell phone is wrong, but I'll have to fix that. The email will come to me directly, so feel free to email me if you have any questions or if you want to join the DNA-related listserv, you can send me an email. Okay. So I hope everybody has had time to take the poll. I'm going to leave it up for a few more minutes just to make sure people do have time to complete it, but I'll probably close it in about 5 minutes. So I am really thrilled to have a really experienced and wonderful speaker today. Jennifer Pierce-Weeks is joining us. She is presently the manager of the Forensic Nurse Examiner Program at Memorial Hospital in Colorado Springs, and previously served for 12 years as the director of the State of New Hampshire Sexual Assault Nurse Examiner Program. She has 23 years nursing experience and is an educator and expert in the areas of child and adult sexual assault, as well as domestic violence. She's a contributing author for several Attorney General protocols in New Hampshire and is published in the Journal of Emergency Nursing and the Journal of Forensic Nursing. She is past president of the International Association of Forensic Nurses and has served on the IAFN board since 2006. She is also a consultant with the NSVRC, the National Sexual Violence Resource Center, National Sustainability Project, and maybe Jennifer can mention at the end of the webinar what that project is about. She's a consultant, she has extensive experience as a local and national trainer as well as a clinician, and is an item writer for both the adult and pediatric sexual assault nurse examiner certification programs through the IAFN. So I want to welcome Jennifer and give her the floor now.
Thank you, Elsa.
Sure.
Welcome, everyone, this afternoon to this presentation, and hopefully it generates some interesting dialogue. So to begin, just as a reminder, I guess, I know that there are multidisciplines on the call today, that there are some graphic images in this particular presentation. They're not horribly graphic, but they are graphic, and they do involve our patient populations. I think there's no way to understand this work sometimes without seeing it. We can talk about it and peripherally understand it, but not personally really engage in what the work of some of the forensic nurse examiners are without actually seeing it. So, so some of these are graphic. Also, I think it's important to understand that no one does this work without experiencing the trauma we watch others go through. So nobody does it without having a personal impact on their lives. And addressing our own trauma needs to be key to our healthy survival in this field. So I just feel sort of obligated to say that. The other thing, because we're going to be talking about a variety of different patient populations today, is that I think it's important to remember that in almost all circumstances, the victim is the one in control of the process of both the examination and evidence collection. Nothing in medicine is 100%, but by and large, this is built on the premise that the victim is in control of the medical processes.
Hey, Jennifer, it's Ilsa. I'm sorry, I'm interrupting you real quickly just to say that some people are having trouble hearing. Is there a way to, can you get closer to your microphone or yell? Somehow ramp it up, just bring up the volume a little.
Is this better at all? I'm literally right on the phone, so.
Okay. I'm trying to see if there's a way to turn you up, but we'll just try to, I guess, just try to project as much as you can. Okay, thanks. Sorry about that.
Okay, no, that's okay.
Okay, that sounds better, whatever you were just doing there.
Okay, I will talk louder.
Okay.
I always feel so loud to myself that I hate to get actually louder than I am. So hopefully everyone can hear me, but I thought it would be prudent to differentiate between what we consider sexual assault nurse examiners to be and what a forensic nurse examiner is as we define it in our community. So a sexual assault nurse examiner is a registered nurse who has received special training to provide comprehensive care to the sexually assaulted patient, and that can be from birth through the elder population, including expert testimony when that is appropriate. A forensic nurse examiner in our community is a sexual assault nurse examiner who has additional training to address the needs of other forensic patient populations. So this is very sort of community dependent, I think, and for us, the nurses in our program attend, aside from their original sexual assault nurse examiner training, they attend additional advanced forensic nurse examiner course through the university system in our city that is a 3-day course addressing the health implications for intimate partner violence victims, for child maltreatment victims, for elder abuse victims, and victims of human trafficking. It's all very geared to what would be the appropriate forensic nursing response to these patient populations. So as we get better at this, I think the educational components shift and change a little bit, but again, it's very community specific, and I think it may look different from place to place. And we'll sort of talk a little bit more about this as we go through. Our program specifically sits right in the middle of a fairly large emergency department. It's a 79-bed emergency department at a city hospital. There are only 2 health systems in our city, and so ours is the city-based program. There are no other forensic nursing programs at the other health system. So right now we have 11 forensic nurse examiners on staff. That includes me as the manager. So of the 10 clinical staff, even though I still practice clinically, it's not my primary role as manager. So the 10 staff that are practicing clinically, 4 of them are in-house and 6 are on call. But the program has 24-hour availability for any patient. It is not just the sexual assault population, but it is all those patients that I have previously described. This is just a little photograph of some of our space. Currently, within that 79-bed emergency department, we have our own specific examination room, which has an attached bathroom and office. So we have a little 3-room suite, so to speak, right smack in the middle of the emergency department. I will tell you that we're currently looking at expanding that space because our numbers of patients, since we have expanded beyond the sexual assault patient, has increased so dramatically, which I'll show you as we get further into this discussion, that we really are very limited in space at this point. So that's just an example of some of our space. How we end up consulted is a different matter altogether. Now, when the program that I'm in now started, it started solely as a sexual assault nurse examiner program. And the SANE nurse is the primary care provider for the sexual assault patient population. So 3 years ago, we began adding other patients, so adding the intimate partner violence patient, the child abuse patient, and those patients we consult on as an additional healthcare team member, whereas the sexual assault patient we see as the primary care provider. The other patient populations are somewhat different. We are part of an entire team approach, really, to those patients. So the folks that consult with us are, and this is pretty close to in order of how often we get consults, get folks asking us for consultations. The emergency department physicians and nurse practitioners that work throughout our ER call us to ask us to consult. The regular emergency department nursing staff call us. The social work department calls us, particularly the pediatric hospital that is within our system. The pediatric social worker and our team are pretty well connected. We have nurse liaisons in our emergency department, and they often, because they do a lot of social support type things for the patients, they often will consult us. But so do the in-house staff. The in-house nurses and physicians will consult us and ask us to see patients. We also have a fair number of patients that come into our emergency department specifically to see us at the request of outside physician offices and clinics. So there are several urgent care clinics surrounding us that will send patients our way, and particularly pediatrician offices will send patients as well. And you'll see that our pediatric population is fairly large. But also, because we have now 4 in-house nurse examiners, one of the things that is expected of those in-house staff is to actually be watching the emergency department board, if you will. So the emergency department has those 79 beds, and on computer you can see who's in what bed and what their chief complaint is. And so when we first began, and it continues now, 3 years later, the nurses are looking for patients, because for sure one of the things we discovered was not everybody's going to call us and say, oh, listen, I need a forensic nurse. We would have to find some of the patients that need us that maybe the staff weren't immediately identifying them as forensic patients. And this includes domestic violence patients. So for the first year that there was in-house staff, really they found, quote unquote, a lot of domestic violence patients that needed our services. So so we also go seeking in the emergency department those patients. We have started the process of beginning to round purposely onto the pediatrics and pediatric ICU units, because we have so many consultations from that area of the hospital. So we find patients as well as other folks consulting us. But we also have pretty good working relationships both with our crisis center and law enforcement agency. And so they will frequently, particularly with intimate partner violence victims, they will bring the patient in specifically with the idea in mind that they need to see a forensic nurse as part of their overall care. And I'll sort of explain what we do when that happens. And it's our policy as well as process to automatically 100% of the time on the adult populations we see call the crisis center and engage the advocacy community, because we're clearly aware that we do not provide ongoing support and services in this format at all. And so to the extent that we can have the patient introduced to that crisis center advocate right at the point of care, we really feel like they're more likely to follow up. And a lot of the times the law enforcement aspect, when they bring patients in, it really has a lot to do with particularly intimate partner violence strangulation victims. We see a fair number of those folks every year. So, so that said, some of our typical patient populations we've talked about a little bit, but because we see sexual assault patients also, and they tend to be our primary patient focus, we also now in children see straddle injuries. And honestly, this is because when children present with straddle injuries, folks can just assume that sexual abuse is not part of the differential diagnosis and walk by it. And in fact, this has happened, and so sometimes we will be called by the operating room staff because they've had to repair a patient and discovered that, in fact, this is not a straddle injury. So in all instances of childhood straddle injuries, we're automatically consulted by the ED staff. Intimate partner violence victims, obviously, as I mentioned, and strangulation, whether or not it involves intimate partner violence, we really see an extraordinary amount, in my opinion, of strangulation, both of women and of children. And so sometimes it's the intimate partner who is strangling the adult woman, but there are also children who we're seeing who are being strangled by their parents, and so we're seeing those folks too. We consult on, our goal is to reach 100%, but 100% of the abusive head trauma children that come in to the emergency department simply because there have been several cases of co-occurring abusive head trauma and sexual abuse, and enough so that it's clearly, from our standpoint, a co-occurring factor. And so we will become involved both from the sexual abuse standpoint, but also from the critical need to accurately document this child's full head-to-toe exam. We see child maltreatment generally, and I'll talk about what we do when we go in for those cases. Elder abuse, honestly, it is just really starting to be on our radar screen, so we're just now starting to see more elders, and I think that's appropriate. I think our numbers will continue to climb as we get better at identifying those patients. And then we have just engaged with a local community agency who works with trafficking victims so that they can access both their immediate health care needs and some of the follow-up health care needs using our forensic nurse examiner team. So that's still in process. What I will say from a DNA perspective, I know it may not seem as though there is necessarily DNA to be collected off of these patient populations, but that's not really what we're finding to be true. For the IPV victims in particular, and specifically the strangulation victims, we do a fair amount of collecting biological evidence off of the patient's neck in a strangulation attempt. Depending on the nature of the assault, we collect evidence from underneath the patient's fingernails. There's a fair amount of other types of physical abuse that go along with IPV and strangulation, and so it's not unusual to see bite marks on patients where it is appropriate, and we will automatically collect samples off of that bite mark to look for saliva to corroborate the history given to us by that patient. So there is a fair amount of evidence collection in this patient population that is not dissimilar from the sexual assault evidence collection. But I guess from my perspective, probably one of the most important things to remember about evidence is that while DNA is critical, it isn't the only evidence, and so our entire record becomes evidence, from the history given to us by the patient to the physical findings that are documented, and the photo documentation that we obtain, as well as that DNA-based biological evidence that we may collect in the process of the overall exam. And I just think that's critical to remember because all of that information is typically used in criminal trial proceedings. As I said sort of in the beginning, that the adolescent and adult patients, they really guide the exam, so including their ability to decline parts of the process if they choose. So all of that is very much explained to patients up front. It's very different taking care of child victims because typically in care of all children, there's somebody else that you're obtaining consent from. And this is, I mean young children, I don't mean the adolescent population, but you're obtaining consent from a guardian or a parent. In some circumstances, you're obtaining consent from a child protective service worker or law enforcement agent. But lots of times when it comes to young children, the consent piece is a matter of establishing rapport with the child. And all I have to think about is the number of children I've examined for sexual abuse evaluations and what they have completely agreed to as far as their exam. And so by and large, the nurse's rapport with the patient really directs how that examination takes place and frankly, what they will and won't agree to as the exam moves forward. This is just one example of some of the many strangulation cases that we see in a year here. But, you know, again, beyond that DNA samples, you certainly can collect skin cells off of the neck of victims if they're coming in right away, and you can collect saliva samples if there's some indication that the person has been bitten. But in addition to that, you can see in this image, these two images, the severity of injury involved here. And so we do a great deal of training with our local medical providers in the emergency department, our local law enforcement, teaching them about the lethality of strangulation in living victims because, you know, I mean, unless you're dealing with medical examiner cases, which we do not do, there is still lethality and risk of death associated with being a living strangulation victim. So we do a fair amount of teaching in that regard, and we want to be able to show both in our written word documentation and the photographic documentation the level of force used to produce this type of injury. As far as the child maltreatment cases, for those of you who are in the medical community that are on the call, I think you'll understand what I mean when I say this. There is a limit to what an electronic record can produce, or at least so far what I've seen of the electronic record. There's a lot of charting by exception, and so you really can't get a sense by reading an electronic record of precisely what did the examination of this child, adolescent, adult look like. And so one of the things that can really help with that is the level of documentation that forensic nurse examiners do. So even though we certainly have the electronic record, we typically don't utilize very much of it. Our consultation report may go in there, but there are always attached body maps and diagrams. In the instances of young children, there are attached growth charts and histories that look like sexual assault nurse examiner histories in quotes given by the patient or the caregivers. This just happens to be the child on the left is a 4-month-old who was seen in the emergency department and had massive subdural bleeding and a head circumference of 54 centimeters, which is just huge. And the nurse examiners were engaged to consult with this child, and one of the things that happened as a result of that I think sometimes may get missed in these types of cases is we discovered that there are a variety of other children in this home. The twin, who you see next to him, who also had a 50-centimeter head circumference and not as massive but still present subdural bleeding, and we actually engaged the law enforcement and child protective service community in getting these other kids in the household in to be seen so that they could be completely worked up, because this little boy had subdurals, his brother had subdurals, the 18-month-old sister could not walk. Her head was so large she could not walk, and while she no longer had present subdurals in her brain, I'm certainly sure she was developmentally impaired. So, and as it turned out in this particular case, there turned out to be a very large suspicion of sexual abuse and a sex offender living in the home. So there's a lot that can be said for using forensic nurse examiners who have the time to spend speaking to the guardians who are bringing the kids in, gathering histories, talking to children who can speak to us, seeing what they have to say, and then documenting the full exam. And in addition to, I mean, this is obviously a child maltreatment case, but sometimes there are child neglect cases, and this is just a little 7-month-old who was roughly 4 kilos at 7 months old, and so being able to, when you're writing this in the electronic record and all using words and not using photography, doesn't really tell the story, in my opinion. Now, the other interesting thing is that in cases like this, sometimes it's not neglect. Sometimes there is a physiologic reason for the child who has failure to thrive. And so we will go back up into the PICU, back into the PEDS unit, checking on these kids often and seeing how things are progressing. And so you see that there are physiologic reasons for things and not necessarily child maltreatment. And your mind has to be open to all possibilities in this type of case. But honestly, there are a host of really significant child maltreatment cases that we see, and this is two children actually. They're two Russian children who were seen by our team, and they had been adopted into wealthy American families. 2 years prior to us seeing them, they had been adopted out of a Russian orphanage, and so we're pretty suspicious that prior to them ever being adopted, there was a fair amount of sexual abuse that had occurred for these children. But being adopted into a wealthy American home didn't change the fact that they ended up very malnourished. So they had been with this family for a couple of years, and when we saw them, they were extremely malnourished, and there was absolutely no protein in their diet whatsoever, which children need to survive. And so there's no way that we, as forensic nurse examiners, work sort of in a silo as a nurse examiner, being the only party seeing these kids. Obviously, a good portion of the kids I have just shown you have been admitted to the hospital for care. They're under the watch of a pediatrician, a pediatric social worker, the in-house staff. We are simply a consult to really better document exactly what the circumstances are leading up to them needing health care in the first place. This is actually a woman that we saw, and she didn't know her attackers. She was walking home at night, and it was a group of women actually who attacked her, which is pretty unusual. And the mark that you see by her nose is actually from a stiletto heel used on her. And so in this instance, we did do evidence collection in the hopes that anybody would be found who could be held responsible for the crime. But we think also that there's a possibility that in this instance it was a hate crime. So we see a fair amount of abuse, as you can see. Just to give you an idea of what this chart represents, and specifically, hopefully helpful to those of you who are SANE nurses who are on the call, in 2007, which is when I joined this team, what we were seeing was solely sexual assault patients, and the total of patients we saw that year in 2007 was 263 sexual assault patients. And for our team, that's all age groups, because every one of the nurses is expected to see both children and adults. And that is about the time that we started expanding our practice. And so in 2008, you can see these are just the sexual assault numbers. These are all the patients all together. So in 2008, we saw 316 sexual assault patients, so still a little bit of an increase from 2007. But total, we saw 429 patients, so 113 non-sexual assault patients in 2008. And everything has continued to rise from that point forward. So in 2009, we saw 387 sexual assault patients and 583 patients total, so almost 200 non-sexual assault patients. And that was pretty remarkable. I thought we might plateau there, but that's not quite what happened. So as of the end of August in 2010, we've seen 318 sexual assault patients and 575 altogether. So 257 non-sexual assault patients. So the theory, if you build it, they will come, it sort of applies to this program and what we have been able to do. And I really think that the documentation on these patient populations is far better than what it was before the nurse examiners were seeing them. And for sure, evidence collection is at least being done where in the cases that it can be done, whereas prior to us seeing the patient, there's no way that evidence collection was being done on any of the domestic violence victims, for instance. So huge increase in the patients that we see. Some of the challenges, though, that are worth mentioning, again, particularly for those of you who are looking at potentially expanding your practice, are that other professionals, they only see us as SANE nurses. And so I think that probably 5 times a week I say we're actually the forensic nurse examiner program. We're actually the forensic nurse examiner program. No, we're not just seeing sexual assault patients because a lot of other disciplines can't get past the fact that we're the SANE nurses, quote unquote. So that all by itself is a huge challenge. But really the biggest challenge is showing the healthcare system that there is a huge need for these other patient populations that isn't being addressed by basic healthcare approach. Without the forensic nurses, it's not, all of their needs are not being addressed. And so, so that has been sort of one of my goals the past couple of years, is really convincing the healthcare institution that this is a patient population that needs support, that needs adequate documentation, that needs to be offered at least the evidence collection portion of their health care. And it's been very successful, but I'll tell you the reason that it has been successful is because we have shown them increasing and increasing and increasing numbers, and we happen to have an extremely supportive administration for the program. They see the value in the program, and so, but if you're not in front of your administration and talking to them about what it is you do and that it isn't just sexual assault, they may not have any sense of what a forensic nurse even is. They think what a whole bunch of people think, which is, you know, we're evidence collectors. Well, it goes much beyond that. So, and another challenge that we really faced was addressing reimbursement issues. We're still in process with this. Reimbursement for sexual assault care is easier, hands down, than reimbursement for domestic violence cases and child maltreatment. But we're still, you know, what we're trying to avoid doing is accessing legal services for the reimbursement. We're, from a nursing perspective, doing things like increasing the level charges for the ED nursing visit, for those of you who are nurses on the call. We're doing things like that. And we right up front give all of our patients information on victims' compensation so that should they need it later, that they know exactly how to access it. Between us and the crisis center services that are provided, they at least know there are a couple phone calls they could make and get some assistance with that. So reimbursement is certainly a challenge. And I guess that the last challenge that I would say that is for sure a management perspective challenge is, you know, making sure that the staff are not getting traumatized in a way that makes them want to leave the business, and making sure that that their own needs are addressed, their own trauma needs are addressed, even if they don't recognize themselves as having trauma-related issues. I think, again, as I said in the beginning, it happens to everyone. And so turnover tends to be pretty darn high with this work, and I think some of that can have to do with trauma-related issues, and some of it has to do with as much as the CSI effect has made people more interested in what we do, there's nothing about our work that looks like a CSI episode. So it looks a lot different in reality taking care of these folks than it does in the media. So all of those things are challenges to really expanding practice, but I think it is a huge service to the patients that we take care of when we do. I see dramatic improvements in the level of care even having somebody out there who is having a conversation with you, whether you're the ER doctor or the pediatrician or the social worker, about what you're seeing. Because for sure, talking about these cases between the nurses and between the other healthcare professionals, including law enforcement and the crisis center, is extremely helpful, I think, and healing sometimes. So all of those are challenges, but obviously, as you can see, it didn't really, none of those have been insurmountable, because I really feel like our team is as strong as it ever has been, and we're doing a really good job serving our patients. So that is the very short version of expanding practice beyond sexual assault. And with that, I think, Ilsa, we actually will have time for questions, which is good.
Yeah, we actually we do. Thank you. We've gotten a couple, but I wanted to, can you mention the, just because it was in the bio, can you talk for a second about the sustainability project?
Oh, sure. The National Sexual Violence Resource Center for, I think it was 2 or 3 years, had a SANE sustainability project. And that project was one, I was simply a consultant on the project. The project was actually run by Jennifer Markowitz and Sally Lasky. But that project looked at SANE programs who were really in critical need, like they were failing, they were not making it. They were given the opportunity to apply for technical assistance to try to make suggestions, recommendations on how to improve their program so that it could be sustainable over the long term. And so many different sites were chosen across the country. Many sites applied for assistance, and it was a project where there were 10 consultants. I just happened to be one of them, and we all made different site visits, really did very intense evaluation of the site and recommendations. And honestly, I just have to say, because now you have given me the forum to say it by asking about this project, that the biggest thing that was found across the board was really that if the focus of the SANE program moved off of the overall health care of the patient, the overall medical approach to that patient, then they were more likely to not be sustainable. That really, it very much is, successful programs are very much wrapped up in providing the health care services to these patient populations, so at least as far as SANE goes. So I think there's still a report pending nationally on that, and but there's a lot more information about the SANE Sustainability Project at the NSVRC website, which is nsvrc.org.
Okay, great. Thank you. So I think you covered the reimbursement issue well. This question came in while you were talking, so I have to say I missed a small piece of what you said. So I'm just going to ask the question, and maybe you can reiterate the answer. But the question is, where does reimbursement come from for FNEs? And the person asking the question says, in our state, SANEs are reimbursed through the AG's office. So I know a lot of states have SANE funds, but they might not have funds for this larger work that you're doing.
Sure. Yeah, exactly. That's one of the issues, is that there are typically each state, and they all, of course, look a little different, so that's very helpful, that everybody has their own reimbursement system set up state by state for sexual assault exams. And so how you get reimbursed for the other exams, I can tell you how we do it, but it is not that the forensic nurse examiner program gets reimbursed. What happens in our system is that any patient who's an ER patient, and again, this is in process too, so you're probably not going to be completely thrilled with all my answers here, but when the patient is an ER patient and we do a consult, say on an intimate partner violence strangulation case, then what happens on the ER charge end of things is that the level of nursing charge increases. So where the reimbursement comes from is completely the same as where the reimbursement comes from if they're in the ER and they have chest pain, right? If you're in the ER with chest pain, there's a physician charge. There are usually radiology charges, and then there's a level nursing charge that happens as a result of the number of hours spent with the patient, the number of hours requiring one-on-one care, that type of thing. The same thing applies to us. If the patient has health insurance, that health insurance is reimbursing at whatever rate they reimburse, right? If the patient doesn't have any type of health insurance or Medicare or Medicaid, then it is that the patient is billed for services. Most healthcare institutions that are not for-profit have some community benefit program so that there may be a system within your system that can help take care of the cost of that exam. So that's another way. But the other thing that we do, as I mentioned, is, if the patient is, let's just say the patient is self-pay, and they get a $600 emergency department visit bill, when they're billed for that, if it's coming out of their pocket, they're also given the information, if they have reported the crime, the information on that reporting of the crime, the law enforcement agency they've worked with, and the information on accessing victims' compensation. Because it's not like they weren't a victim of crime. They were still a victim of crime. They still have access, from a reimbursement perspective, perhaps. It depends on your state, but they still have access to victims' compensation services, which may be able to assist them in paying that bill. So it's very dependent on your community and how you set your program up. But is there one standalone reimbursement system for these non-sexual assault patients? No, there isn't. It's not that simple. And we ourselves are still working on a better access to resources to cover the costs of these exams for patients so they can at least know that they're all right. Does that answer the question?
Yeah, I think so. Thank you. Sorry, I had myself on mute.
No, that's okay.
I'm having trouble coming off of mute. We have a couple more. Let's see. We have about 10 more minutes. So is there a crisis or formal debriefing required after high-risk cases or all cases, for that matter?
Debriefing is not required after cases. And honestly, we do a fair amount of debriefing among our team members. But if there are cases where somebody was particularly impacted, then we will have a formalized debriefing if somebody feels that's necessary. And it doesn't have to be the person we feel who is the most traumatized. It can be anybody requesting the service. You know what I mean? It can anybody coming to me and saying, look, I think we need to do a debriefing or something on this case. And the team does a pretty good job, I think, taking care of each other insofar as, like, for instance, one of our team members mentioned to me, this is several months ago now, I think so-and-so had a really hard time. We had a run on cases of child sexual abuse that required operations to repair the children. And there was just a run on cases like that. And they are very traumatizing cases. And one of the nurses was really having a lot of difficulty not getting those visions out of her head and so forth. But it was another nurse who said to me, I think so-and-so is having some difficulty with us. And that enabled me as the manager to sit down with her and say, look, here are some things to watch for. Totally normal to have a response like that after a case like that. But if you see these things ongoing, I want you to come back and see me. If we need to try to pull together everybody who's in the operating room, we can do that. So I think you have to be open and able to have those debriefings. But we personally, at our program, we don't mandate it. We do a lot of debriefing among the team.
Okay. Thank you for that. Let's see. I'm just going to see if other ones came in. Okay, here's one. How did you convince the hospital to increase your FTE hours with your SANE nurses to incorporate this piece?
Yeah, that is a great questions. So, Elsa, maybe you can back up to the chart on the numbers that I showed?
Yeah.
Or not. Maybe
I can. Yep, this one?
Yeah. This is how I convinced them to increase the FTEs. There is no better way to prove need than showing the institution numbers, because it was fairly easy to actually, first of all, I have a very supportive director, so I will just say that. If you have a completely non-supportive, then it becomes more of a challenge. But numbers help. And so being able to go to, at the 2008 point, I started asking. It didn't happen overnight. In 2009, it became really apparent that our numbers were just going up and that this wasn't going to stop happening, really, at least not now, and certainly not in this economy, because we see many more abusive events during a bad economy than we do when everybody's doing okay, or the majority are doing okay. So being able to show them these numbers and actually saying things, like just making the argument. So here are the numbers, and here are the numbers of staff. They haven't changed at all since the program opened 15 years ago. It's all, what it was then. And the numbers have more than doubled. And that really was the argument. And because if you think about it, but you really have to put it forward as a nursing service. It's a service to patients. So that's how you put it forward to your hospital. It's a community need and benefit that you're offering, but the numbers are increasing, and there's no other nursing specialty that would have doubling in patient numbers and not the support needed to take care of those patient numbers. But sometimes we don't promote ourselves as nurses because it's very, again, it's very, people really do look at us as an arm of law enforcement, and we need to really bring our healthcare institutions back to the fact that, no, this is nursing practice. It's an identified nursing specialty, and in any other specialty, if there were these kind of increases in numbers, there would also be resources put into taking care of these patients. So that's how I convince my director. And good luck to all of you who are on your way to trying to convince yours. It's not an overnight thing, for sure.
It seems like they could use some of the information from your program, though, to be
you're
helpful.
Welcome to email me and ask for anything that we have, whether it's, our policies, whatever it is you think that we have that might be, assist you in some way, by all means, send me an email.
Okay, great. Here's one about strangulation that I think a lot of people might be interested in. In regards to strangulation victims, how do you notate those injuries that do not necessarily cause bruising, because most victims of strangulation do not have bruising at the time of hospitalization? So,
can you reread the question?
Yeah, I think the question, I was just reading it just directly, but actually now I'm paraphrasing. I think the question is, doesn't some strangulation cause bruising that doesn't show immediately? So if somebody's coming to the hospital immediately after the incident, is there a way to notate notate that so that there's an acknowledgement that there may be bruising that hasn't shown up yet? I'm hoping that's the right question.
Yes, okay, that makes sense to me.
Okay.
So a couple things. So the first thing is, roughly half of our patients who are strangled don't have any injury. And it's not that they are going to get it later, it's that they never develop it. And that doesn't make the strangulation event any less lethal. We have a specific strangulation tool that we utilize when we talk to those patients, so we can have a very accurate recording of specifically what happened during the one or multiple strangulation attempts. So as far as that goes, I'll just put that out there, that some people have injury that never shows up. I mean, they never have injury that is present and, photographable. There's just nothing. But those who come in right away, we actually say to them, it's possible that these injuries will get worse with time. It's also possible they'll just completely disappear. If they get worse, please come back in. Call us, come back in. We want to see you, do a further assessment. We want to re-photograph. And And we also have specific discharge instructions that we give to the strangulation cases for the very critical things that we need you to come back right away for. If you start seeing certain signs and symptoms, we consider those critically important that we see you back right now. And all of that is in our discharge paperwork. Now, hopefully that answers the question.
Yeah, and if it doesn't, then the person who asked it can email you?
Yes, absolutely.
Yep. More information. We have time for one more, I think. Can you talk a little bit about what your nurses do in the ER when there's not a forensic patient in the department?
Yes, I can. They would be happy if I did that. 100% of our charts have quality assurance done on them. So nobody is ever allowed to do a case of any kind at our program where there isn't another nurse at the program looking at their entire documentation of that, from photographs to colposcope photographs to the chart itself. So, and we have specific quality assurance scoring tools that are used to document their scores, because they're expected to have a pretty darn high score on all of their QA. And so there's a fair amount of quality assurance that goes on when we don't have patients. But as you might imagine, if at the end of August we had 575 patients, we don't have a lot of downtime at our program. So we do that. We also we are the people who take care of our own images. So there's a whole bunch of image storage that we do as in-house people to make sure that no photographs are lost or sent to the wrong place or the wrong record. And so there's a lot of downloading of images, whether they're from the digital camera or the colposcope. There is, we have systems in place with some of our partners, Colorado Springs Police Department and Child Protective Services, where we, having worked with them on this for a bit, they believe it improves their investigation to have the entire chart from the kid's visit or the adult's visit, if that person is willing to release it in adult cases. On the front end, it assists their investigation. It gets their investigation started faster, and so we fax records out of our office, and we maintain HIPAA compliance on the stuff we do. So there is a fair amount of just general boring paperwork and chart review and image review that goes on when there aren't patients. Most of the time, though, there are patients.
Okay, thanks. We have time for one more question. We have a couple questions that we won't be able to get to, so we will get Jennifer to answer those and send those in writing. But this one I think would be a good one for everyone to hear. How has the FNE documentation been shown to impact the courtroom or an increase in identifying perpetrators?
Okay, two totally different questions. So can you read the first part again?
Yeah, actually. So there's how has I'm guessing really the use of FNEs and the documentation they do impacted the courtroom, which is pretty broad, or you could maybe even start by talking about how it's increased in identifying perpetrators.
Okay, so you'll really not be thrilled with my answer here, but that's a great question, but it's probably a great question for our district attorney's office and for our law enforcement agency. And the reason why I say that is not only because I can't answer the question for you because I don't know, but also because I don't track our cases from the legal outcome perspective.
Okay. That's a fair answer. It's okay to say that we don't have it, or that there's somebody else has the answer. So maybe we could work on finding some of that information. Okay, so we are out of time. I don't want to keep anyone later than we have to. I wanted to mention that we did reopen the poll. If people haven't taken that took the pre-test or the pre-poll, if you could do that. I think we have about 10 minutes left on that, and I'll leave that up for a little while. I just really want to thank Jennifer for sharing her expertise and experience with us today. And we did record the presentation. I know some people said they had issues with sound, so I'm sorry about that. We recorded it, and it will be made available probably early next week on our website, and the PowerPoint presentation will be there as well. So I will send an email out to everyone when that recording and when the PowerPoint is noted or posted on our website. Just remember to visit our website to learn about the future webinars, and there will be an evaluation that will pop up in a little box when we sign off, and if you could fill that out for us, that would be great. And thanks again, Jennifer, for your time. Do you have any closing comments you want to make before we sign off?
Just thank you very much for having me.
Okay, wonderful. Thanks so much. Everyone have a great afternoon.